This is a really intriguing story, at least over the last 2 to 3 years. It was not very long ago that Julie Bramer first had a presentation at ASCO documenting the activity of nivolumab, a prototypical PD-1 inhibitor, in the second, third, fourth, nth line setting in patients who had received multiple prior treatments. Response rates are about 18 to 20%. Initially, there seemed to be some preferential benefit in squamous cell that did not pan out over time. Then we saw a presentation by Suresh Ramalingam from Emory documenting in phase 2, again in patients with extensive prior treatment, a 15 to 17% response rate for nivolumab exclusively in squamous cell carcinoma of the lung. I think this year, 2015, we've witnessed two incredibly important trials that really have changed the therapeutic landscape. The first is Checkpoint 017, which compared nivolumab, given at a standard dose every 2 weeks, to standard docetaxel, which until this year was our standard of care in second-line treatment of non-small cell lung cancer. The improvements were really quite pronounced. We observed a major improvement in response rate from about 9% to nearly 20%, a statistically significant and clinically meaningful improvement in progression-free survival, and most importantly, a stark improvement in overall survival, a 3-month improvement in median and nearly a doubling in 1-year survival rates. Almost overnight, from the report of that study, nivolumab became the standard of care in the second-line setting in advanced squamous cell carcinoma of the lung. This year at ASCO, Checkpoint 057, an analogous trial in non-squamous non-small cell lung cancer, showed very similar results. Perhaps not quite so striking, but again, a response benefit and most importantly, a survival benefit. And here too, although it does not have an official designation, it certainly has a compendia listing. Nivolumab is now included in the NCCN guidelines for both squamous as well as non-squamous. And docetaxel has been relegated to third line or clinical irrelevance, depending on your attitude toward the drug. In both cases, without question, nivolumab was far safer, far less toxic than standard docetaxel. So PD-1 inhibitors are here to stay. There are important distinctions between squamous and non-squamous. The benefit for nivolumab in squamous was seen regardless of PD-L1 expression. In non-squamous, again an exploratory endpoint within the context of the phase 3 trial, the survival benefits were much more pronounced in those who had PD-L1 expression, no matter what cut point was used, whether it was 1% of cells or 5% or 10%. We see across the board about a 10 to 12-month improvement. In the absence of PD-L1 expression, that survival benefit is lost. It's no worse than docetaxel, but it doesn't appear to be any better. Nevertheless, it's far less toxic, so effectively it still replaces docetaxel in that setting. So we have to be very careful regarding immunotherapy. If you go to the specific trials, there are a number of exclusions, particularly regarding autoimmune disease, pre-existing interstitial lung disease or IPF. Those individuals are almost always categorically excluded from clinical trials. So that group needs to be studied separately. Are we posing a specific threat in that group? Will we reactivate their autoimmune disease? What about individuals with Crohn's disease or ulcerative colitis, things of that sort, or pre-existing collagen and vascular diseases? All of these individuals, and they're not uncommon, these individuals were excluded. Beyond that, though, immunotherapy, specifically nivolumab, at least for the time being, has become a standard treatment in the second-line setting in advanced non-small cell. It's got FDA approval in squamous cell, and it's got essentially de facto compendia approval in non-squamous. The big question, of course, is whether there's a role in frontline, and that's a much higher bar. We have to be very selective, and most of the clinical trials that have looked at these agents have been selective, evaluating specifically those individuals whose tumors express PD-L1, and then comparing single agent PD-L1 or PD-1 inhibitors to standard chemotherapy. Ongoing, our number of trials are actually combining chemotherapy with these PD-1 and PD-L1 inhibitors, again in the front line. And initially, 2-3 years ago, I was highly skeptical. Now I'm increasingly optimistic that we're going to see advances.